My name is Melissa Eiper, and I'm here to talk about my behavior change project. HIV is known as human immunodeficiency virus. It is a virus that can lead to acquired immunodeficiency syndrome, or AIDS. Unlike some other viruses, the human body cannot get rid of HIV. That means that once you have HIV, you have it for life. There currently is no safe and effective cure, but scientists are working hard to find one. Meanwhile, with proper medical care, HIV can be controlled. Treatment for HIV is often called antiretroviral therapy, or ART. It can dramatically prolong the lives of many people infected with HIV and lower their chance of infecting others. HIV affects specific cells of the immune system, called CD4 cells or T cells. Over time, HIV can destroy so many of these cells that the body can't fight off infections and disease. When this happens, HIV infection leads to AIDS. There are two ways you can classify AIDS. The first being that if the individual's CD4 count falls below 200, or the individual has one or more opportunistic infections. There are 4 modes of transmission of HIV. They are blood, semen, vaginal fluids, and breast milk. With this in mind, there are several groups at risk for contracting HIV. One group is the IDU community, or the injecting drug users through blood. Another group is the pregnant mothers when they deliver or breastfeed. Sex workers and the MSM community, or men who have sex with men. It is important to note that MSM does not mean that the male is gay. It just means that he is a man who has sex with men. In some instances, the man can have sex with men and or women. For my intervention, I am targeting condom use among HIV-positive men who have sex with men. In order to increase condom use among this population, there are a number of things that need to be addressed. When the individual goes in to see their healthcare providers, they will have the option to attend a group session geared toward learning on how to talk to your partner or partners about using condoms without having to disclose their status. In the group, there will also be an educational session on how to properly use condoms. As well as providing the group with this information, they will also be informed of the condom distribution program that is being implemented. The distribution program is found throughout areas that the MSM community frequents. These are bars, clinics, restrooms, just random dispensers, malls, campgrounds, bowling alleys, etc. There will be condoms that they can take free of charge in these areas. By receiving the educational sessions as well as getting the tools they need to implement, there should be an increase in condom use over a 6-month period. They are questioned at the start of the intervention, halfway through the intervention, and at the end of the intervention on condom use. For example, if an individual reports a 0% condom use at the start of the program, it should increase by the halfway mark, or 3 months, and increase again at the end of the intervention to the 6-month mark. Over time, there should be a 100% condom use. The theory I am using for this intervention is the social cognitive theory. It is composed of 3 main parts: self-efficacy, goals, and outcome expectancies. In order to implement the theory properly, the key components of the theory must be utilized. The first is reciprocal determinism. In order to utilize this, the individual will gain access to specific venues to allow the condom distribution to take place and inform the clients that they can access them. This ties the individual to the environment. The next is through behavioral capability. This is done through the group sessions on the knowledge of how to talk to your partners, as well as being able to use condoms. They will have the skills needed to implement the behavior change. The expectation is that after completion of the intervention, there will be a 100% condom use with partners and talking with all partners about using condoms. The self-efficacy component is that the individual has the confidence to talk to their partners for not only their safety, but the partner's safety as well. It provides safety to both individuals because the partner is being protected against HIV, as well as the HIV-positive individual by not having to disclose their HIV status if they choose not to. Observational learning is done through the educational sessions in group. This is modeled for them in regards to proper condom use through demonstrations by instructors and situational learning through examples. For example, in the sessions, the individuals will be required to perform mock sessions on talking to a partner about condom use. So, for example, group members 1 and 2 will have to pretend to talk to one another about how they would address to their partner on why they should start using condoms without having to disclose their status. The last component is the reinforcements. There are many different contributing factors. One example of positive reinforcement would be that each and every time they use condoms, that partner is protected against becoming infected with HIV. An example of negative reinforcement would be not utilizing the condom distribution program and not being able to use protection, ultimately putting their partner at risk for contracting HIV. The reason that this intervention sticks out is because not only does it provide education on how to talk to their partners about condom use without disclosing their status, but it also promotes proper condom use in conjunction with a condom distribution program. It ultimately provides a safe and effective way to increase condom use without having to disclose their HIV status. Thank you.